Welcome to week 2 lecture. I've decided to present information on screening and assessment because I really would like you to have a good grasp of assessment for your assessment 1. So before we kind of launch into how to conduct screening, assessment and case formulation, I guess I have some thoughts around what might inform the way in which we approach assessment of clients with drug dependency or alcohol dependency. I think it's really important for us to have an understanding of addiction as a developmental disorder. And that's also kind of flowing into or aligns well with a trauma-informed perspective, which we looked at last week. Now, this is really, really important because more recently addiction has been found to be profoundly shaped by the learning that occurs during critical periods in childhood and also adolescence. And it's become widely accepted that it now belongs under what we call the neurodevelopmental conditions umbrella. So think of other sort of conditions such as ADHD, even Asperger's, that also come under that umbrella. Now let's look at the fact that brain development, we know now it can't occur appropriately or I guess properly without key experiences. So almost any disorder that affects mental functioning in childhood and adolescence has a learned component. So when the importance of learning and development in addiction is better understood, many of the contradictions that we see that leads to misunderstanding what addiction is about are resolved, and it then becomes easier for us to understand why it's neither a moral failing on anyone's part or nor a brain disease narrowly in terms of that traditional medical model, that it's far more complex than those two models suggest. Now, what we know about learning disorders is that timing is critical. Healthy development unfolds in a precise pattern, and the sequencing of environmental influences, particularly social ones, is critical. Missing an experience may seem trivial at one stage of development, but can also derail an individual at another stage of development. During the sensitive periods of brain development, which are infancy and adolescence, if specific input isn't received by an individual, and is therefore missed, it's really then difficult for that person to play catch up later on. As development is sequential, it then influences when we time our intervention, because it can change the course of addiction depending on when it occurs. Now, let's look at this idea of addiction being a maladaptive coping style. You'll see this come up in your textbook and across your readings. What does it mean? Well, addiction is a coping style that occurs for people who predominantly rely on avoidance as a long-term coping strategy. Now, avoidance is really interesting because I think most of us in the short term tend to avoid difficult feelings, particularly distressing and painful feelings, and we tend to avoid some situations in our life. Now, avoidance short term has a place. You know, we do tend to engage in some levels of avoidance. However, when it becomes your long-term way of dealing with life in general, it really increases that risk of developing addictive type traits. Addiction is considered maladaptive when the behavior persists despite ongoing negative consequences. And this persistence occurs because of a concept called overlearning, which is related to reduced brain plasticity. And this is what makes behavior extremely resistant to change, behavior that is addictive. Plasticity is about the brain's ability to learn to change with experience. And lowered plasticity means that this ability is then undermined and a pattern of behavior becomes sort of locked in or overlearned. Overlearning is a feature of the brain's motivational systems, which has evolved for our protection and survival. And the strong drives of this motivational system is really helpful. It drives us to do better parenting, to love well, to be able to achieve in our study and work. However, intense resistance to change becomes almost like a glitch in our programming when drug taking or unhealthy activities, sorry about the misspell, continue in the face of ongoing harm and negative consequences. Addiction alters the way the brain decides what it values. It actually makes things like heroin and cocaine seem epic and all other experiences pale in comparison. So when we're working with clients, one of the biggest challenges for us is to empower our clients to unlearn maladaptive avoidant coping. We're wanting them to become attenders, to actually become very active in their coping style and attending to life and problems rather than self-medicating and trying to reduce emotional distress by numbing life out using substances. So let's zoom into why adolescence is a high-risk period for people. The research tells us that adolescents, so I'm thinking about that bracket of 13 to 24, it's no longer up to 18 now. We know that adolescence and brain development doesn't really stop until 24, 25. It's a high risk period because this is when the brain changes to prepare an individual for adult sexuality and responsibilities. And when people begin to develop ways of coping that will serve them for the rest of their lives. So, for example, the odds of alcoholism for those who start drinking when they're 14 years old or younger is nearly 50%. But it immediately drops to 9% for those who start drinking at 21 or later. The risk of rapidly developing addiction to marijuana, cocaine, opiates, pills like Valium is 2 to 4 times greater for those individuals who start using at the age of 11 to 17 compared to those who start at 18 or later. So if you can manage to make it through your teen years and early adulthood without developing an addictive coping style, the odds of you developing one at a later time, it isn't non-existent, it still occurs, but they're dramatically reduced. Now, this information is really important when we're assessing the onset of use of either alcohol or other substances. So again, looking at addiction from that developmental learning perspective, it's interesting because this theory says that people outgrow their addiction. And this is reflected in the literature. We see people generally, if they have used in their 20s, 30s, generally by their early 30s to mid 30s, people just start to move away from substances. This is because developmental conditions such as addiction are generally outgrown. We also see this with people who are diagnosed with ADHD in childhood. They tend to outgrow those symptoms. Developmental conditions like addiction involve delays in timing of brain maturation rather than being a permanent lack of ability. So people may be lagging developmentally, but when they're supported and I guess exposed to a range of healthy experiences, particularly in counselling where they're exposed to psychoeducation and other ways of being able to do life, they can play catch up with respect to changing addictive behaviours. So I thought I'd just add that to some of your learning. I don't know that it's covered too much in your manual sections, but I think it's really, really important for you to continue to question and develop your own perspective in terms of understanding addiction. So let's zoom in to what this particular lecture is about. We're looking at formal processes undertaken when we're conducting assessment. We're seeking to understand what is happening for our clients around their struggle with a substance. So I want you to conceptualize this as a process where we begin with screening, we then move into assessment, we then move into case conceptualization, and sometimes that's also referred to as case formulation. And those three top processes, screening, assessment, and case conceptualization, then inform the way in which we intervene or treat the client. So depending on whether you're using counsellor speak or psychology speak, we talk about intervention and psychologists talk about treatment models. So when we embark on these formal processes, it's really important for us to check in what's informing our framework for practice. For me, it's always about seeking to understand. That allows me to suspend judgment and to increase my empathic responding to my clients. So before embarking on formal processes, we need to ensure that we're seeking to understand the client's presentation and the set of circumstances that have perhaps led them into a life of addiction. This is working from a trauma-informed perspective. So rather than asking, what have you done, and almost triggering shame and blame for the client, we're always asking, what has been happening for this person that has led them into these behaviors? We're not wanting to collude with shaming or blaming, which is the predominant sort of dialogue out there in culture or society. Rather, we're wanting to observe and understand with objectivity and to suspend judgment. All right, so let's look at this idea of assessing substance use dependency. We're wanting to gather as much information as possible to formulate an accurate assessment of a client in relation to their alcohol and drug use. Screening and assessment tend to be ongoing processes, particularly assessment, and they need to be incredibly accurate. It's almost like a jigsaw puzzle, and you're gathering as many pieces as possible to formulate a really clear picture. The focus should be on the client's current issues and what their needs are. That's going to inform a client presentation. We're also wanting to assess the reason for the client seeking support, and generally there's been a tipping point or crisis that triggers a client engaging in support seeking. And the counsellor also needs to suspend judgment again and provide a safe environment in which the client can explore various options relating to their use or misuse of preferred drugs. So zooming in, let's look at screening versus assessment. Now, the purpose of screening is to determine whether a client needs further assessment. And then the purpose of assessment is to gather really detailed information needed for treatment planning that meets individual needs of the client so that you can tailor intervention. There are many standardized instruments and interview protocols that are available to help us perform appropriate screening and assessment of clients. Screening involves asking questions carefully designed to determine whether a more thorough evaluation for a particular issue or disorder is needed. Many screening instruments require little or no special training, so I'll be sharing with you a range of screening tools that are used in AOD, and I'm actually wanting you to access those and name those in your assessment one. Now, what's the difference between screening and assessment? Screening is a process for evaluating possible presence of a particular problem. Assessment is about defining the nature of that problem, determining a diagnosis, and developing specific treatment recommendations. So I'm going to pause here and then move on to a second screencast now that we're hitting 15 minutes. Thanks.